We actually have a couple questions involving anterior segment surgery. And one of them that I'll maybe direct to both of you is that there's a recent trend in pterygium surgery, this so-called perfect technique, pterygium extended removal followed by extended conjunctival something, that involves dissection over the medial rectus. And are you seeing strabismus after these techniques, or are there other anterior segment surgeries where you're seeing a lot of strabismus?
I haven't personally not seen the specific that you mentioned, but yes, in Los Angeles, I have the opportunity to treat some patients with a procedure that was called the eye bright, where the entire conjunctiva was removed, so you can eliminate the redness on the eyes. So there was no conjunctiva no more. So those eyes really didn't move. The eyes were white, but they didn't move. And I don't know if Dr. Dimmer had the opportunity to see some of those patients as well, but not for these pterygiums.
We've had a couple pterygium that have had tight medial rectus muscles. Now, I think David Granite's got a paper that he presented, and I think it was in Journal of APOS maybe 3 or 4 years ago, that he was able to recess the medial rectus with an amniotic membrane. It's a large series, 8 to 10 patients. But our experience has been similar. You have to recess the medial rectus there to correct the strabismus.
Great.
You can't just take the pterygium off.
You mean introduce?
When the deviation is small, you can, very small meaning less than 5 prism diopter. We had a paper with Rosenbaum many years back. Then those patients do well. But I think for those who like doing this, you can do it under topical anesthesia. It's even better. So you can explore really well the medial rectus, and then you can assess the patient intraoperatively. I think the biggest concern that I personally have is if you like adjustable sutures, because with the amniotic membrane in place, it's going to be a little bit tricky how you do your adjustable suture. You cannot put it anterior. You have to kind of redirect the sutures to go posterior to the graft. And also, I mentioned it a couple of times, you have to be careful when you place the fibrin glue, because you can actually create a reverse restriction that will end the patient having exotropia in the field of action of the medial rectus muscle that is equally bad as having esotropia in abduction.
Yeah,
Many of these are like that video, though, that somebody showed here before, where the eye just goes out and just gets restricted right at a -4, and those you have to relieve the restriction. A small angle, you can probably just take the pterygium off. Agreed with Federico here.
Yeah, the perfect technique was developed by Laurie Hurst in Australia and involves a very meticulous and time-consuming destruction of the medial rectus pulley. And his rate of strabismus following that procedure is something on the order of 40 to 50%. It would be probably unacceptable in most places. The pterygium never recurs, but the strabismus is also hard to eliminate. So I had the recent opportunity to operate on one of these. And although an amniotic membrane had been placed, it immediately degenerated, and the caruncle became adherent to the medial rectus insertion. So with a lot of dissection, I was able to free it up and corrected it with a conjunctival autograft. But I would discourage your colleagues from doing the perfect technique unless you like doing these difficult muscle cases.